Our next speaker is David Hebert from New Orleans, and he's the director of ECMO services at Heartbeat Perfusion Solutions. He spoke with us last year, did a fantastic job, and we'll do it again.
Hey, good afternoon. How you guys doing? Can you hear me well? Okay, so after these great presentations, I realized two things. One, all of my stuff's been covered already, and my pictures probably going to disappoint you, but I'll do the best that I can. So my talk today is about ECMO and how it works in your center. So by no means tells you how you should do it, just kind of what you do on it, because I think the beauty of ECMO is that, so I'm an RT, so we have NBRC tells us how to be a respiratory therapist, what our scope of practice is. But ECMO, there's no such thing. There's ELSO who suggests what we do. AMSEC has ideas also. But after 24 years in this field, I've talked to so many people across the country, across the world, that what they do at ECMO, I'm thinking, wow, are you nuts? Are you killing people, right? But then they're doing a great job because what they do is a little bit different, but it works. I've had people come. So I was at Children's of New Orleans for the majority of my career as a program manager. So we'd have people come in from other programs to work for us or as locums, and they would just say, we had a very busy circuit, but it worked well for us. So I had to often defend that. But again, we had pretty good results like most people. So the talk today is about really, what ECMO, how the diversity of ECMO is, and coming from more of a program manager, coordinator aspect, just to kind of own what you have. So I have no disclosures today. So what are we going to talk about? What I just said. I'm sorry, I jumped ahead a little bit. I do tend to speak a little fast, so if I speed up for you, just throw something at me, wave at me, whatever, just let me know, okay? So anybody here really love ECMO? I'm pretty much an ECMO nerd. I admit I talk to my friends across the country and I'm like, hey, how's your family? How's ECMO, right? So I admit I'm a bit of a nerd. In fact, this was my screensaver for my phone for quite a while. Then my wife made fun of me, so I got rid of it, put a picture of my wife. So this is, the guy, the father of ECMO, Dr. Bartlett. I don't know if you guys ever met him. I met him about 4 or 5 years ago at ELSO in, I think we're in Phoenix or Austin. He spoke. I went to one of his lectures and sat there like the little. Remember when the Beatles came out? I was like a fangirl. I admit, I've got to meet this guy. So he came down. I pretty much stalked him and tackled him, kind of. In fact, we're dressed the same almost. So I took a picture with him and talking. He's a lovely guy. Met him a few times since. Just a great guy. His birthday was on Monday, actually. I didn't stalk about that. I just saw it on LinkedIn. So lovely guy. So we talk about cannulation techniques and management. So again, Clifton and Bill and other people have talked a lot about this. And so some of this will be some repetitive things, but just kind of our aspects. So when you come to cannulas, we have so many options, right? There's so many vendors out there to talk about. So we have, I'm not going to read every one. We have Medtronic Biomedicus and all their stuff, Tandem Life, more Medtronic, Gettinga, more Medtronic. You could tell we use a lot of Medtronic in my old center. Cooks, Polystan, Edwards, Beers. So again, there's so many different cannulas to look at. So you want to make sure you have the right one for your population. For a neoped center, we didn't, some of these didn't really fit for us, but what we used, again, so I'm preaching, use what works well for your center. So then also we have different vendors, you have also different characteristics. You have arterial and venous cannulas. You have a DLP, Biomedicus, OptiSite, Venus, VV double lumen cannulas, long right angles, short right angle, metal tip right angles, malleable cannulas, single stage, double stage, triple stage. So you want to look at also, someone I think Clifton said earlier, look at flow ratings. You want to make sure they're right for your population. You want to make sure to have good depth markings on there. So when you look at x-rays, you really can tell what the tip of that cannula is, because of course it can make a huge difference in your patient safety and improvement. Radiopic aspect, I just said that, sorry, I got ahead of myself. Make sure you have the right introducer. Some cannulas, cannulas will come without the proper introducer, so we have to order that separately, so kind of be aware of that. Side holes for kind of like a Murphy's eye for an ET tube, same thing. Make sure you have suture, some of them have suture collars. Again, numerous size selections. And then so kind of a coating, right? Because the coating is kind of a big thing for circuits and our cannulas. You hear about everybody's got the best coating in the world. And is there really a best coating? I personally don't think so. Maybe you may. But we all know that after a couple of hours on ECMO, maybe a couple of days, that coating probably is gone already, because you get so many, you get so much flow going through. You have hemolysis starting at some point, fibrin strands. So a lot of that gets washed away. Again, whatever works for your center, use it. But we know that it goes away after a while. Some of the cannulation techniques. So you have percutaneous, you have a cut down and central cannulation. Again, coming from a neopede center, we didn't have any fem cannulations. No axillary or anything like that. So you have percutaneous, where basically just kind of, as Clifton said, you kind of tunnel in there and so this could be done by a surgeon or a ICU physician. So that's kind of variation on different centers. So some of the pros, and I'll repeat some of this. So some of these are really highly successful. Suggested to be paired with ultrasound guidance or fluoro. Can be performed by trained intensivists. Lower infection rates. And some of the cons could be difficult without ultrasound guidance, possible hematomas, infiltrations, and that. Next could be the modified or known as a cell dinger technique. We actually open up the skin, isolate the vessels, and cannula directly to the vessel. Some of the pros, so it's a direct visualization device or cannulas, vessels, visualization of bleeding sites. So if you have bleeding, it's easier to open it up and correct that bleeding if you need to. Some of the cons: increased risk of infection because of being open per se. Time to cannulate. So one thing I didn't say earlier, and maybe I did, I'm sorry. So if you do sometimes with the percutaneous, sometimes it may be a little bit quicker depending on the skill of the surgeon or physician. So that could, but sometimes, usually when you have to open up the skin and isolate the vessel, it takes a little more time to do that. Then you have central cannulation. These are usually patients coming out of the OR from post-cardiotomy, cardiac surgery, kind of when they crump in the OR from stun or something like that. You'll see them centrally cannulated, excuse me. So some of the pros are you have direct visualization of the aorta and the right atrium and other aspects of the heart, of course. You have improved control of bleeding. Some of the cons are you have an open chest. Now, I've seen some surgeons cannulate centrally but still close the chest for infection risk, decrease infection risk. So that's pretty interesting. Increased risk for infection. I keep getting ahead of myself, I'm sorry. Maybe some increased bleeding, but you usually have better drainage and possibility of additional cannula. So it's if you need more flow, you have your carotid or your other vessels that you could use also. They're not used up already. The next aspect, talk about securement. So we want to make sure patient safety is priority, right? We want them to get better, but we have to be safe about it. We have to be smart. We have to be proactive and speak up. I think like Clifton said, you need to speak up, make sure you're there for your patient. And that, if not, then you really shouldn't be at the bedside. That's kind of, so you want to make sure it's safe, right? So I'm trying to go back. So this is something we did when I was at Children's, and probably a lot of people do this. It looks maybe kind of wonky, but it worked for us. So we have the tubing holder directly onto the isolette, and we have umbilical ties. And sometimes we would, right below where you see we had tape, foam tape, kind of holding the cannula together onto the bed. And then here you see another aspect of it, just making sure everything's secure. It looks good. It's not tugging too much. There's not too much. Sometimes too much slack could be a bad thing also. You want to be careful with that. And then here's some different variations of securement. Anybody here working at an ECMO program where you're walking patients or ambulating the patients? You are? And how's that go? It works well? You like it? Okay. So I think it's interesting. I wish we could have done that where I was. Nice. Good. Okay. Yeah, everybody thought I was crazy because we'd have occasionally the older patient on ECMO, and I thought, let's wake them up, let's walk them. And if this thought I was just speaking another language, but I think it'd be interesting to do. Again, picture some bleeding and some security of that. Everybody does, again, a little bit differently, but having a gauze over and some Tegaderm kind of worked well for us. And then, of course, one thing we did for our program actually to think about is make sure you include wound care for your consults, because before we had wound care coming on, we had about a 73% increase incident of infection and breakdown. So what we did is we started up a process where I met with them every Monday, Wednesday, Friday. We went together to the bedside, lifted the patient, looked to make sure there's nothing under them, and we went from 73 to 11% incident of skin breakdown. So if you can think of something like that for your program, please do it. And administration will love you because it saves money on return visits for that. Good for the patient, but make sure it's, again, administration will love you for it, trust me. So security, again, so you want to be careful, right? This is a 4 a.m. cannulation for a COVID patient who came from another state. And we're ready. Patient has been coding for about 30 minutes. So do we go on? Yeah, let's give this person a shot. Ready to go on, cannulas in, handing up the circuit. And it was a I'm not gonna say the brand, but you could actually press that connection. You could disconnect the circuit from each other. And someone handed it up to the surgeon, and they hit the wrong disconnect button, and we had blood all over the floor. So luckily, we had 2 units of blood on the unit. We were able to reprime with some albumin, also get the patient on. So again, when I say security, just being really careful what you're doing. Take your time. Yeah, you want to hurry because it's not a slow moment, but be positive of what you're doing. And that goes to backing up to having drills, right? Having maybe mock cannulation drills and making sure your therapist or your specialist, know how to handle the circuit in the proper fashion. So a little bit of patient management. Again, so I'm not gonna read all this. This is ELSA guidelines. I think we all should follow ELSA guidelines to a certain degree. Yes, some of those may not work for you, but I think most of it really kind of makes sense. And I think really what's important, make sure your physicians understand this and have a good knowledge of basic ECMO inclusion criteria, Again, more ELSA guidelines, just I think, the more you bring to the program and build policies, and it will help. And different uses for ECMO, of course, bridge transplant, sepsis, COVID, which we all have dealt with that, I'm sure. Status post bone marrow transplant, uncontrollable bleeding, and you don't want to have you want to make sure you have reversible conditions, Early intervention, so we talk about, we need to go on ECMO. Time is crucial. That's why we have ECPR programs, That's why we have people in-house sometimes who can cannulate, or actually our specialists who can prime a circuit and initiate ECMO. And then, we also have some miracles here and there. We kind of put them on late. We think we're not going to win, but we win. So it kind of works well. Sedated awake, so I just kind of brought that up earlier, and patient population specific, want to talk about safety. I can say this, I know at Duke they do tons of lung transplant. I was talking to one of their surgeons a couple of years ago, and he was telling me they'll put them on ECMO and they'll trach them the next day or that same day, and they're up and walking the day after to decrease the metabolic demand, and so it makes a big difference. So again, I would love to have stuff like this, but I thought I was a bit crazy. To ventilate or not. So, right, as we know, you don't, if you're on VA ECMO especially, you don't really need an ET tube. You're on ECMO. So there's different aspects of each program. See, this patient's on a face mask and a high flow, and this patient's looks like she's intubated. So again, population specific, and make sure communication. I actually had a patient with VV ECMO probably about a year ago. Was an asthmatic, I believe, and the ET tube she was intubated en route, so the ET tube was really small, so we had a huge leak, and so the docs were freaking out. So basically, we we deflated the cuff and took her off the ventilator, put her on an anesthesia bag of like 5 a peep, and we did that for the duration of the course. And this reduced alarm fatigue on the ventilator because it kept reading low minute volume, and so people were running for nothing. And that's one thing I always hated was alarm fatigue, right? Because it just creates a poor environment. But so you could, there's different ways to do it. Patient did well, by the way. There's a blank screen for you to enjoy. Prone positioning. Some places will practice this either before ECMO or on ECMO. Yeah, thanks. I do think I'm the funniest person in the room, sorry. Occupational therapy makes a big difference to your patient. Physical therapy, if you have that available for your patient population, again, and ambulation if possible. And one last thing, wound care. I said that earlier. So end of life, so that's really rough, right? Because we spend weeks or days with the family, especially in the neo population. And if you're a parent, you have a lot of empathy. You feel for them. It could be an adult too. So it's hard to have those talks, right? You make sure you want to have palliative care come in even from day one to kind of, even though the patient does well, it helps with, they have somebody to talk to, kind of like with social services, palliative care. Again, if you have pastoral services, please introduce those to the family. And saying goodbye is always the hardest part, right? And then home ECMO. Everybody heard of home ECMO before? I used to make a joke about this for many years. I was going to open up a company to do ECMO at home. That way it'd be easier. But this has kind of been the thing of the past. A new thing. Say what? Yeah. I don't know if it is. Okay. I love making fun of Bill. Bill has been a great mentor to me, so it's fun. So I heard stories before. We have patients end of life on ECMO, and their last request is to go home and see their garden or something. So I've heard of stories where they'll put them in a truck or ambulance, drive them home, let them spend a couple hours at home, bring them back home, and take them off ECMO. So it's pretty impressive. Again, so let's look at pumps. So we all, have been doing this a while. Start off on roller head. I know roller head is still being used a lot. And then centrifugal pumps, again, whatever works for your patient population. I think it's imperative. So, just to name a couple of few. CardioHelp, Centromag, PDMag, Sorin, spectrum, and tandem heart. Again, so circuitry, patient management, like I said, we had a very busy circuit. This is what we had at Children's, the Sorens. So as being so used to the circuit, it was easy for me to go to the circuit and do anything. And I realized for new people, I need to make it a little bit easier and less confusing. So what we did, again, we used our circuit. We gave everything to our circuit. I know it's a no-no in some places, again, but it worked well for us. Some places have only give it to the circuit or the patient, both, and again, busy circuits. So what I did, I keep jumping, I apologize. I labeled all of our pigtails that we had. We had like 8 of them, what they were used for, because sometimes you could give things in different places, but I thought we should have a standard. That way, at 2 in the morning or 2 in the evening, Christmas night, whatever, it's the same thing 24/7. So I kind of labeled where we gave things and made things a little bit easier for people. And I think when travelers came on board, it was less confusion because they're using other places to do things a little bit different. So I'm getting some thumbs up, so thank you. Again, circuit coding, I talked a little bit about this earlier. Does it really make a difference? Right, we go on ECMO, we have this huge inflammatory response, vasodilation, everything goes crazy for a little bit. Circuit is a really large surface area, so when you're giving products, you have all this blood, extra 2 liters of units of blood in the circuit, whatever. It's it's adhered to the wall. You have bioactive, biopassive coatings. Again, depending which company vendor you use, may be good for you. And again, like I said, after 24, 36 hours, has there ever really been a test out there? I think each of the vendors have done their own tests. It's a little bit biased, but I don't think anyone's ever done out there from a non-partisan aspect to see which one's really the best. But again, I guess the jury's out. Labs on your patients. So of course, we all do labs and probably sometimes way too many labs, right? What's the best frequency? We did way too much. I recently did a trip to a center in upper states, and they did labs every 12 hours. What I thought was crazy, but it worked well for them. So anticoagulation, we all have to deal with this, right? Heparin-free circuits, DTIs, antithrombin 3. Just remember, if you're a neoped center, remember most patients are AT3 deficient, so sometimes you may have to give that to your circuit. We did. It's very expensive. Administration doesn't love that, but if you could prove that it's best for your patient, then again, maybe you may be able to win that. So we all have done ACTs, right? Is that the best policy? Some places, yes. Anti-10A, PTT. This turns really slow, doesn't it? Sorry, PT. D-dimers, AT3 again, and plasma-free hemoglobin. That's something we didn't do at Children's, and I'm not trying to speak poorly of the institution, but it's something I wanted to do. So I would reach out to some of you in the room probably, and just all kinds of other people, and I want to learn more about it because I didn't know much about it. I've educated myself since then, and I think it's a great tool to use, and I think if you could talk to your program manager, your medical director, and even any other ECMO physicians, bringing something like it on board really makes a difference. So I say go for it. Component changes, oxygenator, you make sure, you can have the pressure gradient grow, but my thought process was, yeah, it's growing, but if we're still producing good PO2 and blowing off CO2, why change it? Why risk all inflammatory process again? So, reading pulse ox blood gases, increased flow demands, increased sweeps. You want to watch all that and just kind of gauge it. We had this one patient for 12, 13 days. We changed out 4 oxygenators. And it was the beginning of my infancy as an ECMO manager. And, kind of like you said earlier, you're new, so you're kind of scared to speak up because you want to kind of earn your boundaries. But I decided we would quit never doing that again. Somehow that patient survived. So we went to a process where if we're still producing PO2s and we're close to coming off, we're not changing it. If we have to limp off and the kid's good, fine. If we're on day 3 and we think we have a week to go, yeah, let's change it. But if you get limp off, go ahead, go for it. And then also the same thing for the circuit too. So we all know what clots look like. They can be really ugly sometimes. And so when you look at the oxygenator, your gradient's growing. Of course, it tends to be in the corners, like we say. So you may see something like this after a case. We'd often wash out our components. We thought there was some significant clotting. And so I kind of use that to educate the team and the physicians what it really looks like. So one thing we introduced was primers. So, I kudos our perfusion team. Couldn't be here without you guys. But we only had 2 perfusions. So if one person was out on vacation and one guy is in the OR, we had to put somebody on, we had to wait. I thought, that's not safe. That's not okay. So I started training some of the cream of the crop of our team, or people who wanted to do it at least, because maybe the cream of the crop didn't want to do it. So we started doing that, and we was able to increase cannulation times, especially at night. We would go on I did a study about 14 minutes earlier. So if somebody's crashing, 14 minutes is a long time. So you want to make sure you catch it early. So we'd have people on call, and again, it would help perfusion out tremendously. And again, like, we're going to ECMO much quicker. And then, we did lots of training because, it's not something you do once. You go, hey, I'm a primer. No, you do it over and over and over again. So I was really proud of that team back there. So in review, what I said is probably preaching to the choir. You guys know this. But I just, again, I like expressing different ways of ECMO. Again, this is not all of my ideas. It's ideas from across the world, people I've talked to. So, so if you need me later, I'll be on my boat. Anybody can come by except Bill. But yeah, please come aboard. We'll have drinks and hang out. Thank you for having me, PDC. And if you have any questions, I'll answer now.